Hello. Hello. Thank you for your kind introduction. Yeah, I'm gonna start my presentation now. I think. Okay. Hello, everyone. My name is Shuhi Li. I'm currently working as a graduate research assistant at University of Exeter, and it's really my honor to present my work at the conference. And this work is based on a joint research project during my master's study in health data science at Exeter, and I collaborated closely with Certus Technology and the Torbay and South Devon Foundation Trust. So for today's talk, I will focus on three main sections: the background information, the development process of our model, and the outputs of our model, and briefly discuss the implications and limitations. So first, for gastrointestinal endoscopy, it is a medical procedure that allows physician to examine the patient's digestive system by inserting a long, flexible instrument called endoscope. It includes the lower GI endoscopy that is inserted through the rectum and the upper GI endoscopy, which is done through the throat. NHS endoscopic services are facing challenges in mounting demand and constrained budget, particularly post-pandemic. Research has shown that in the first 3 months of 2021, only 57.9% of endoscopic services met the urgent cancer weight, and even less for the routine and surveillance weight. Also indicated by the latest diagnostic test
Sorry
report.
to interrupt you
Yeah.
there. The slides on the screen, we can see it's not full screen. We can kind of see, and they don't seem to be moving on.
Okay.
So now that's better. That's it. Yeah.
Yeah. Okay.
You can
Okay.
see that now.
Yeah. Sorry.
Sorry.
Yeah. Yeah. Okay. So for the like showing by the latest diagnostic test report, like only 28% of patients undergoing endoscopy services, they were still waiting for more than 6 weeks. So in response to these challenges, demand and capacity modeling has become an essential tool for optimizing resources across various services. So regarding the demand versus capacity, there are three main scenarios in endoscopy services. The capacity mismatch problems are commonly observed between the lower and upper GI services. For instance, a over-provision capacity for the upper GI combined with a under-provision for the lower GI procedures. The optimal situation would be capacity matching demand. To address these problems, the NHS has developed a endoscopy demand and capacity planning model for the medium-term demand and waitlist estimate for the upcoming year in the Excel. However, there still remains a research gap in the short-term endoscopy services planning. Therefore, our project aims to develop a demand and capacity model for short-term weekly resource planning of the endoscopic services using ordinary differential equations. So for the technical tool, I primarily used Python for coding, and SciPy was employed for the mathematical modeling. And the specific mathematical framework I use is called compartmental ordinary differential equations. Like a well-known example of this ODE model is like the SEER model, which effectively predicts the spread of infectious disease like COVID-19. So the model, the SEER model breaks down the infectious populations into susceptible, exposed, infected, and recovered states. We chose this because it perfectly matches our need to track and estimate all state variables at fine time resolutions. So for the first step of modeling, I abstracted the actual care pathway from intensive meetings with our clinical team. This is a diagram showing the workflow. So both the upper and lower endoscopic investigations are requested by GP, where three main pathways: the routine 6-week referral pathway, and the 2-week pathway for the urgent suspected cancer patients, USC patients, and those planned referral pathway for those who require ongoing surveillance. So next, patients from the routine and the USC pathway, they move into the active waiting list, and those from the planned referrals, they move into the planned wait list. When their appointments are due, patients report to the reception, undergo the procedure, and they are typically discharged on the same day. During our modeling process, we solely focus on two main procedures, OGD for esophageal gastroduodenoscopy and colonoscopy. Next, we have conducted exploratory data analysis on the operational data collected by the Torbay and Devon Trust from 2020 to 2024. As shown in the figure, the blue lines are the upper GI referrals, and the orange are for the lower GI referrals. We can see the routine lower, routine upper, and also urgent lower referrals were the three predominant sources. So for the wait list, we can see that the number of patients on the planned colonoscopy list was the highest, especially in 2022, and active colonoscopy and active OGD list, they both observed a spike after the pandemic, and the planned OGD list was the smallest in size. For the activities, both OGD and colonoscopy, they show a similarly steady increase in the weekly procedures done. So based on our understanding of the care pathway and also the operational data, we started to build our model. So we broke down the whole process into interconnected compartments, including referrals, waiting list, admission, in-procedure, and discharge. So considering the various sources of the referrals and different types of wait list, we have there was a total of like 18 compartments. To simulate the realistic fluctuations in the patient referrals, we introduced a seasonality and a stochastic variable, representing both the periodic and the unpredictable fluctuations as our input. And we also introduced a carrying capacity constraint on the admission rates to reflect the capacity limitation, such as theater rooms, personnel, equipment. And we could use this term to cap the admission rates from the wait list to the active procedures upon reaching the maximum capacity. So for the model output, we mainly use the length of the wait list as our primary outcome to measure our model's accuracy. So here are the predictions and the 95% confidence interval from the multiple rounds of our model. So the blue lines are the actual data point, and the orange lines are our forecast. We can see the forecasting accuracy is better for the active OGD and planned OGD list, and the mean absolute errors are relatively small, but the model was less accurately for predicting the planned colonoscopy list. Another significant feature of our model is scenario test. We can change the various parameters of referrals and also capacity compartment to simulate what-if scenarios, so it can be a powerful tool for strategic planning. After discussion with our clinical team, we have experimented on several practical scenarios, including increasing or decreasing the current number of available rooms, temporarily closing one room for 3 months, and modifying the capacity allocation ratio between the upper and lower GI procedures, and also changing the referral patterns. I want to show you the two scenarios that provide some interesting insights. It's like modifying the capacity allocation ratio between lower and upper GI procedures while maintaining the total capacity levels. This is quite important because our clinical team, they were very interested in addressing the capacity mismatch problem that I have mentioned in the beginning. So as you roll, the blue lines are the actual data points, the orange lines are the baseline scenario, and the green ones are the experimented scenarios. When we reduced the capacity ratio for lower GI and allocated to the upper GI procedures, we can see a significant increase in both the active and planned colonoscopy list, and the peak increase was around like 1,050 individuals. In contrast, when we reduced the ratio of upper GI and allocated to lower GI procedures, the increase in both active and planned OGD list were less permanent, resulting in a peak increase of around like 500 individuals and a much greater decrease in the length of the colonoscopy list. These findings suggest that the colonoscopy waitlist are more sensitive to the changes in the corresponding capacity than the OJD list. This could be helpful for the local trust, like indicating a capacity shift in favor of lower GI procedures could be like more effectively in addressing the bottleneck problems. So to summarize, we have developed a mathematical framework to develop some quantitative insight into weekly real-time fluctuations, and it's a versatile tool to conduct what-if scenarios. And for the limitation, first is the parameter sensitivity, because we have tuned the model based on one local trust. So the generalizability to other settings could be limited without substantial retuning. And also we made several simplifications during our modeling, such as we did not consider the ERCP and sigmoidoscopy and repositioning, rebooking, and patients who did not attend. Finally, I would like to thank all my co-authors, Matt, Mark, Charlotte, and Joshua, for their excellent expertise and vital contributions to this work. And also, thank you all for listening, and please contact me further via email or linking. Thank you.
Yeah, thank you very much for that really interesting presentation on your model. We are at time, and I'm conscious it's the lunch break. So if the crowd has any further questions, please feel free to get in touch, and we can answer them that way. So thanks very much again for that, and all of you that have attended this morning.